in 1958, in an experiment, he compared 0.15 ml intradermally in two separate doses at 0 and 1 month of age, at 0 and 1 month apart, intradermally by needle and syringe, of course, and he got a very poor response here, indicated by the pink circle. He also studied, interesting, giving IPV by the oral route, and of course it failed, as well as intramuscularly. He got actually pretty good results. Samuel, in both 91, 92, and Samuel was part of the T. Jacob John group in Christian Medical College Hospital in Vellore, leading a polio researcher, studied in this study prior immunes, 8 adults and 10 children from 7 to 10 years of age, given them 0.1 ml doses once, and he got pretty good frequency of 4-fold to a 1024-fold booster effect, 17 out of 18, 17 out of 18, 17 out of 18. And he found a greater than or equal to 3 millimeter diameter in duration and erythema at the site of injection, suggesting that they had cell-mediated immunity in at least 12 of the subjects. He then did another study, published the next year, 0.1 ml intradermally times 2 doses at 8 weeks intervals, and here are the seroconversions he got. Pretty good mean of 91%. Nirmal, also in that same group from India, as late as 1998, studied immune-naive infants 6 to 8 weeks of age without any maternal antibody, and he compared 0.1 ml intradermally. Actually, he didn't have a control group. In none of these cases did they have control groups at 0 and 2 months of age versus 0, 1, and 2. I'm sorry, these are 3 doses, and these are not months of age. These are intervals. So at 0 and 2 month intervals, and then 3 doses at 0, 1, and 2 month intervals. And you can see he got very good results here. And this other study here, not quite as good results, in which they looked at immune-naive infants from 6 to 8 weeks of age who did have a maternal antibody present. So it suggests the maternal antibody is not helping things, and somewhat lower immune response frequencies. I'll talk a little bit more about some more recent findings now from both the influenza and polio literature that are of interest. Interestingly, from throughout the entire 1980s and 1990s, there was not a single paper on intradermal influenza vaccination, and it wasn't until the New England Journal of Medicine came out in 2004, as the world was getting worried about avian influenza and pandemic influenza, that 2 papers were published in the same edition by Bob Belshi and Kenny here on intradermal influenza. I don't provide all the details for lack of time, but basically Belshi studied an investigational GSK vaccine in which they gave 6 micrograms per strain of antigen to each patient. In other words, they were dose sparing 60% compared to the typical 15 micrograms. And they used, they don't mention in the article, but they did use this Becton-Dickinson intradermal syringe I'll be talking about later, which has a 1.5 millimeter 30 gauge needle at the front of it that only goes in 1.5 millimeters deep. They compared this investigational GSK vaccine to Fluzone in this formulation, studied adults 18 to 81 years of age, and from the color coding, the results were pretty good. The only exception was in the elderly, in the H3N2 strain, the GMT and geometric mean titers and seroconversion rates were not as good as they were for the sub-Q route, or the IM route, I'm sorry. And Kenny similarly got good results studying the fluorine vaccine given 0.1 ml compared to 0.5 ml IM in adults 19 to 41 years of age. In pediatrics in 2007, Chu also got good results studying children 3 to 17 years of age with the Fluorix vaccine from GSK, comparing 0.1 ml to the standard 0.5. So these were all generally good results for intradermal. Here are some that weren't good, and that's why I used the pink color coding here. Awarakun from Thailand studied in the 2006 season in Thailand a vaccine that was both manufactured by Sanofi but then packaged in Thailand. And they found that the intradermal route performed less well than the intramuscular route in both naive and non-naive subjects who had never been vaccinated before with influenza. However, the results are in green here because they, despite the results being not as good as IM, they still would have satisfied the not very stringent European CPMP criteria to license an influenza vaccine. Patel in 2006 and 2007, and she provided this picture for me here, studied the H5N1 avian influenza strain, and they compared intradermally 3 micrograms or 9 micrograms in 0.1 ml versus 15 or 45 IM in half a cc, and all doses, ID or IM, less than 45 micrograms were not immunogenic. And this is what I referred to earlier, that this strain is hard to vaccinate against. And so in a sense, in the reduced dose group, there was no difference between the two. And when they went back later and compared equal 30 microgram doses, they did find an equivalent effect, ID or IM, presented at the annual conference on vaccine research last year. Now this came out more recently. Belshie went back again and published in Vaccine another study of comparing, in which he actually included equal doses by the ID and IM routes, a topic that later on will have some significance. He studied 18 to 49-year-old adults who had not been vaccinated for 3 years, and he was able to give Fluzone in equivalent quantities by both routes. So there were patients who were getting 3 micrograms IM versus 3 micrograms ID. Patients getting both 6 and 6. In this case, they gave 2 separate doses because it's hard to get 0.2 into a patient. But the patients were basically intradermally vaccinated, but with 2 simultaneous injections to avoid too much in any one skin site. He compared 9 micrograms to 9 micrograms, and then he gave the IM group the full standard 15 micrograms per strain dose. And he found the immune responses intradermally were either better than or equal to IM at all of the equivalent doses. And this is, however, the intradermal local reactions were worse than IM. And this is just one of his tables in the interest of time, the H1N1 table, and you can see pretty good comparability here between when the doses are the same, 3, 3, 6, 6, 9, 9, and 15. And just as an example, fourfold or greater rise, 58%, 62%, 62, 60, 53, 66. So if you go all the way down to 3 micrograms, 58% of the patients were giving a fourfold rise, and the full dose at 15 IM was only giving 68%, so roughly not much better. Now let's turn to polio again. And the reason for interest in polio for this route, for its dose-sparing capability, is that it will be a challenge for polio eradication to switch from the cheap oral polio vaccine to the expensive inactivated polio vaccine by injection for the surveillance period that will occur after the last cases are detected in the world. What they're trying to do is to get live vaccine of any, live virus of any kind, whether it's in the vaccine or in the wild, out of circulation to avoid reversion to virulence. And so the world is going to have to switch to this expensive IPV, which costs 10 times more than OPV. So if they can dose spare, that can help, save a lot of money that's not necessarily easy to obtain for this eradication. So WHO sponsored 2 recent trials of trivalent polio vaccine in 2 developing countries. I won't name them here upon request from WHO, but Roland Sutter was kind enough to let me show this data. And in both cases, they used an investigational intradermal spacer on a bioinjector or jet injector. I'll show you more details about that a little bit later. And this is a photograph from country A. This is actually an example of how not to vaccinate a child. We believe that you should more firmly immobilize the patient's limb, because if during the injection, which might take a fifth of a second, if the patient is wiggling, they can get lacerated from the jet stream. So this is bad technique, actually. And these are his results from both country A and country B, 2006, 2007, or in 2007. Now, in this country, they gave the doses at 6, 10, and 14 weeks of age in these infants. And this one, the more older age schedule that we use in this country, 2, 4, and 6 months. And you can see here, comparing the ID route to the IM route, we have the pink color coding suggesting that it did not work very well. His seroconversion rates are 53 compared to 89 for type 1, 85 compared to 95 for type 2, and 69 compared to 100% really for type 3. So not quite as well. But when they gave it at a slightly older age, it was pretty good, not quite 100%, but close enough. The safety findings were that there were minimal local adverse events associated with the device, and there were actually no serious adverse events to the entire interventions. and their conclusions were that 1/5 of the dose at 2, 4, and 6 months was virtually comparable to a full dose IM, but at 6, 10, and 14 weeks, a younger age, it was suboptimal. They hypothesized this was the result of the maternal antibody effect. I think there are enough other potential differences between the two studies, how they gave the vaccination and so forth, that might explain this. It's possible it was maternal antibody, and it's possible it was techniques. So I'm not convinced that that's the explanation. And they did ask the parents if they liked this method, and they said there was an overwhelming preference by the parents because, quote, the baby doesn't cry. Now let's turn to some promising new methods for cutaneous vaccination. We'll start with adapting an old existing technology. I mentioned earlier those multi-use nozzle jet injectors, the Mungies, that are now withdrawn from use because they're not safe, have been replaced since the mid-1990s with a new generation of disposable syringe jet injectors, DISGs, once called DICGs for disposable cartridge jet injectors. And these are a number of them here. This is the one that was used in a number of the studies. And some of these are now being adapted for intradermal delivery. This is one of them. I mentioned this was used in country A and B for the polio studies. Basically what they do is they take a standard licensed jet injector with the cartridge here and the injector device there, and they put on this 2-centimeter plastic spacer that creates that air gap that weakens the stream. And clinical trials have been conducted for a variety of purposes against cancer, HIV, lymphoma, and malaria vaccines. We're doing, I'll talk about in a minute, a study with this device of influenza by the intradermal route in the Dominican Republic, and I mentioned the polio trial here. This is the manufacturer's cartoon of how his intramuscular with the dose going down here, his subcutaneous with the dose going down here, and his intradermal theoretically works. And here's a photograph actually from the senior investigator in the Dominican Republic of what the wheel looks like when you inject him with saline immediately after the injection. You can get a sort of an instant visual confirmation that the dose is where you want it. This is right before the trigger is pulled, and this is right afterwards. It's a little blurry picture, but it's pretty easy to see that it did get into the skin and stay there. This is from our study, which involves both PATH and WHO with various types of support. And we routinely vaccinate the injection sites on days 2 and 7. This is our very first patient, number 001, on day 2 after vaccination. I think that's the spot. Now, I'm still blinded, so I don't know if this kid got the jet injector or a needle and syringe. This is probably his BCG scar. But we find very, very little local reactions, which I think is the real critical determinant for whether the intradermal route is going to work, because I think immunologically there's a lot of evidence from the literature that it will if it gets in. And this is the results of our phase 1 trial. We had 48 kids, only 1/3 of them, 16, got the jet injector. I still don't know which ones, but if you look at all of them, merged together, very little pain reported by the parents, nobody who had severe pain. One patient who had pain level of 2, cries or protest on touching the injection site, and 17% of them who had a light reaction on touching the injection site, not unusual. Very little erythema, only 15% of the patients with mild erythema, less than an inch in size. 6% of the patients had mild swelling. One patient had a mild hematoma. Nobody had warmth or swelling of the entire limb.